Hello, my name is David Back, and in this module we're going to specifically focus attention on principles of drug-drug interactions, and this will help us as we further develop the course in relation to the direct-acting antivirals. So we'll focus attention on DDIs, we'll understand how some drugs can be the perpetrator or the cause of a drug interaction, and others the victim of a drug interaction. We'll recognize the different mechanisms which can take place, and we'll know that the resultant changes in PK can sometimes be really clinically relevant. So, a patient is taking a drug, and then a doctor adds in another drug. What is going to happen? Caution, a drug interaction could occur. So we need to be aware of a drug interaction when one medication is added to another medication. So always be aware of potential hazards. I'm a cyclist, and you need to be aware when you're cycling of what a driver is going to do. But I'm also a car driver, and you need to be aware in your mirror of when someone is cycling. And certainly in the UK we have signs which say think bike when you're driving, and that's an important message. I want to adapt that and say think DDIs. So if you don't check your co-meds, then you don't know what you're missing. If you don't check your mirror, you don't know if a cyclist is in the mirror. If you don't check your co-meds, then you could be missing something. So think DDIs. And if there's one message I want to get across, it is just that message. Think drug interactions when a patient is on more than one medication. So what is the concept? The concept is that you've got your HCV drug. If we're talking about the HCV drug as being the major drug, what about the co-meds? How does that affect the HCV drug or vice versa? Well, can the HCV drug influence and be a perpetrator of an interaction which will influence your co-med? Or can the co-med influence the HCV drug so that the HCV drug becomes the victim of an interaction? What's our concern? We're always concerned about AEs, adverse events. We're concerned about adverse events that can come from the HCV drug or from the co-med. And we're concerned about loss of efficacy. There's no point in taking a drug if it's not effective. So you don't want the drug to be decreased, so you're losing efficacy of the drug. So in order to understand the perpetrator-victim concept, we need to understand the disposition or the handling within the body of each drug, and we need to understand the therapeutic window of each drug. What is the range of concentrations that you're not going to be too concerned about if an interaction occurs, but other drugs you can be really concerned about the interaction. So going back to something that I think we've outlined in one or two of the previous talks, the key mechanisms of interactions, we're going back and looking at the gut. Interactions can occur in the gut, changing gastric pH, we considered that, antacids, inhibition, induction of metabolism in the gut. We went to the liver, we thought briefly about the induction inhibition of enzymes and transport proteins in the liver, and we thought about renal excretion and the inhibition of drug transporters in the kidney. So these mechanisms now, which we've considered in the past, all have to be in focus as we specifically look at drug interactions. So an important question that we often get asked is about the time course of enzyme induction and enzyme inhibition. And it's important to note that they are different. For enzyme induction, this is primarily to do with the time course of upregulation of the enzyme. It takes time for new enzyme to be formed in the liver. And this would, in a ballpark, be somewhere between 7 to 14 days. With enzyme inhibition, it can occur pretty much immediately. As long as you've got the drug in the bloodstream, inhibition can start. But also to note that it will be maximum when the inhibitor is at steady state. So there's a difference then between the time course of induction and inhibition. What about transporters and de-induction? That's another question we get asked. What about the time course for transporters? Well, transporter induction is pretty similar to enzyme induction because there's overlapping cellular pathways via nuclear receptors that control the induction of both the enzyme and the transporter. As far as de-induction is concerned, you have to remember that once you've increased the pool of enzyme or transporter, that it will take time for degradation of that protein. And that time to return to baseline is normally around 10 to 14 days. So we have to think about time courses of these processes. Now, another concept which is critical in defining the importance of a drug interaction is the therapeutic window. So let's think about having two drugs in a regimen, and the concentration of those drugs in that regimen are in a particular therapeutic window, which is a factor which one has to consider when you're talking about a drug interaction. You have low therapeutic index drugs or narrow therapeutic index drugs, and we have wide therapeutic index drugs. So comparing this slide with the previous slide, these are drugs with a wider therapeutic index. So in terms of toxicity and in terms of the reduced efficacy, you have to consider the therapeutic window of the drug in relation to a drug interaction. So narrow therapeutic window drugs, examples, anticoagulants. So you have to control warfarin levels because warfarin is a narrow therapeutic index drug. Antiarrhythmics, anticonvulsants, oral contraceptives. You have to be very careful about the level of drug from an oral contraceptive, for example, and anything that can interact. Statins, immunosuppressants. So if somebody's on a transplant list and goes into transplant, then you monitor the immunosuppressant level because of the narrow therapeutic index of the drug. So different drugs have different therapeutic windows. So what is the impact of a drug interaction on a patient then with comorbidities and therefore co-medications? Well, it can lead, as we've seen, to an under or overexposure of the antiviral, and that's what we're interested in, or the co-administered medication. This can reduce clinical effectiveness of either medication, or it can increase the chance of adverse events. So always bear in mind these two aspects, that a drug interaction can increase or decrease the exposure and therefore affect the adverse events or the efficacy of the drug. So finally, let's just focus in on a snapshot of the anti-hepatitis C drugs, the DAAs. And you can see here that different drugs have been put against some of those proteins that we've been thinking about. So CYP2C8, CYP3A, OATP1B1, P-glycoprotein and BCRP. And it means that those drugs are involved with those particular proteins either to be metabolized by or to influence those proteins and therefore affect a drug-drug interaction. And down the bottom you see the pH effects with lidiposphere, valpadosphere. We're going to go into far more detail as we move through the course, but that just gives us an overview of how these proteins are important for individual hepatitis C drugs. Is it important? Well, you go into the guidelines which doctors will be using in terms of their prescribing and their understanding of where we are with the medications. These are the European guidelines, the European Association for the Study of Liver, EASL. And in those guidelines it tells us that numerous and complex drug interactions are possible with HCV DAAs. Therefore, the potential for DDIs should be considered in all patients who are undergoing treatment with DAAs. You have to do a thorough risk assessment before you start therapy and before starting other medications to the patient. Similarly, in the AASLD, the American Study of Liver Disease Guidelines, you can see in the second paragraph the assessment of potential DDIs with concomitant medications is recommended prior to starting antiviral therapy. And patients need to be educated on the proper administration of their drugs and the crucial importance of adhering to the drug in order to get adequate drug levels and the necessity of being supervised and really understanding the importance of the whole drug interaction scenario. So in summary, I think what we've seen is that we always need to consider DDIs. Remember, think DDIs. And a knowledge of the mechanisms of the interaction and the therapeutic window is important then to be able to implement a management plan for the patient. And all the individual DAAs and the regimens have DDIs to some extent. So it's not that you have drugs without any DDIs, you have drugs with less DDIs, but we have to think about the interactions for all the DAAs. And in future sessions, David Berger, and then when we deal with cases, Fiona Mara will take us through how we really manage this in clinical practice.